Welcome everyone. Today we are going to learn about a simplified approach to the diagnosis of wheezing in under 5 children. So what is a wheeze? What do we mean by wheezing? Wheezing is a high-pitched whistling sound that is heard usually in expiration. It is usually heard on auscultation, but sometimes it is so severe that it can be heard without stethoscope also. In case of a wheezing child, we have to take some relevant history on an emergency basis, such as we have to ask about the similar episodes in the past. We have to ask about the nighttime or early morning symptoms, for example, shortness of breath, coughing, wheezing, etc. We have to ask about the dry cough, especially a cough that is aggravated by exertion, laughing, crying, and running, which all point towards the presence of a reactive airway. And we have to ask if that dry cough is more in the early morning and night time. And we have to assess the response of that cough and wheezing to bronchodilators. We have to also ask about the family history of asthma or allergy. While examining a child who has wheezing, we have to ensure or confirm that the wheezing is present during expiration, that may be heard without stethoscope or with stethoscope. We have to look for signs of hyperinflation of the chest, like increased anterior posterior diameter of the chest clinically or in X-ray. We have to look for the signs of respiratory distress, which point towards a more severe clinical condition. And we have to check the response to rapid acting bronchodilators by giving salbutamol by either a nebulizer or metered dose inhaler with spacer. We have to assess or reassess after 1 hour for signs of improvement like less respiratory distress, less lower chest wall indrawing, and improved air entry. If no improvement is seen after nebulization or no response is seen to the bronchodilators, we have to look for other causes like foreign body aspiration. The positive points suggestive more of a foreign body include monophonic wheezing localized to one area in a child aged predominantly between 1 to 4 years. So, when a child with wheezing and respiratory distress comes, especially a child under 5 years of age, the first thing that we have to ask for is that does the child have recurrent episodes? What do we mean by recurrent episodes? Recurrent episodes refer to more than or equal to 3 episodes per year. If the answer is yes, that means the child is having recurrent episodes more than 3 episodes per year, then we can classify the child into one of these two groups. What is the first group? In the first group of children, usually the children are less than 3 years old. They are typically associated, the wheezing episodes are typically associated with upper respiratory tract infections. They occur around 6 to 8 times per year, and there is usually no family history of asthma or atopy. And if we follow these children, they usually outgrow their illness. That means with increasing age, the wheezing episodes improve, and later on, the child may not have wheezing at all. These children are diagnosed or classified as episodic viral wheezing or WALRI, that is, wheeze associated lower respiratory infections. That means every infection is associated with wheezing. That's why it is called wheeze associated lower respiratory infections. What is the second group? In the second group, usually the children are more than 3 years old. They may have interval symptoms between the episodes of URI. For example, during sleep, laughing, or crying. That means during the URI episodes, they will have wheezing. Also, in between the URI episodes, during sleeping or excessive laughing or excessive crying, also they may have symptoms of wheezing in absence of all the other symptoms. And they usually have a family history of asthma or atopy. In these children, these are classified as or diagnosed as preschool multi-trigger asthma. If the answer to the recurrent episodes question is no, that means the child is usually not having recurrent episodes, usually 1 or 2 episodes per year, then it can be classified into one of these two groups. What is the first group? In the first group, usually the wheezing is the first episode of wheezing in a child less than 2 years of age. There is preceding upper respiratory illness and or rhinorrhea, usually associated with mild fever. That means this wheezing episode has been preceded short time back by features of upper respiratory illness. There is usually associated nasal discharge, which can cause severe nasal obstruction. On X-ray or clinical examination, there is hyperinflation of the chest, and on auscultation, there are usually fine crackles or crepitations with or without wheezing present. These group of children are usually diagnosed or classified as bronchiolitis. What is the last group? The last group is a patient having cough, fever, and rapid breathing who do not have qualifying features of any of these three. That means the patient will have cough, fever, and rapid breathing. Think, what is the cough, fever, and rapid breathing called? It is usually called pneumonia. So, if a child is having features suggestive of pneumonia, but not the diagnostic criteria satisfying bronchiolitis, episodic viral wheezing, or preschool multi-trigger asthma, then what will it be called? It will just be called pneumonia with wheezing. So these are the four groups into which an under 5 child with wheezing can be classified into. Now, once you have classified into one of these four groups or made the diagnosis, the treatment becomes fairly easy because in a case of episodic viral wheezing or Walry, usually bronchodilators are the mainstay of treatment, and in a preschool multi-trigger asthma, also bronchodilators are the mainstay of treatment. Then what is the difference? You can see the episodic viral wheezers usually outgrow their illness. That means with increasing age, there will be less and less viral wheezing episodes and the bronchodilator requirement will decrease. But in a case of preschool multi-trigger asthma, this has a family history of asthma or atopy. That means these group of children may later on develop into full-blown asthma. So you have to refer to the GINA guidelines, that is Global Initiative for Asthma. Refer to the GINA guidelines for managing the patients with bronchodilators plus or minus inhaled corticosteroids. Coming to the bronchiolitis group, as we know, the bronchiolitis management includes nebulized epinephrine, nebulized bronchodilators, hypertonic saline nebulization with or without supportive care, and pneumonia with wheezing. The diagnosis, if the diagnosis is correct, then the management becomes fairly specific. For pneumonia, we have to give antibiotics, and for the wheezing, we have to give bronchodilators on an as needed basis. Thank you. Hope you have understood the basic diagnostic algorithm for a child under 5 child with wheezing.